exam. All right, that's like the important part. All right, so good afternoon. I am H116, I'll be your IDC student today. Do you need a standby?
No.
Same-sex standby. We have a lot of them. All right, first I'm gonna go ahead and do my vital signs: blood pressure, pulse, respiration, temperature, SpO2. I'm gonna verbalize those, right? And then do you use any tobacco?
Yes.
No?
No.
Right. Okay. I got 30 minutes for this, man, all right? No tobacco use, all right? Do you use any alcohol?
No.
No. All right, do you have any allergies?
No.
Do you use any medications?
No.
And any supplements or stimulants?
No.
All right, how'd you hurt yourself?
I fell.
You fell, okay. So first, in order to start my inspection, I'll go ahead and ask the patient to remove their shirt. Don't actually do it.
Please.
I'm not trying to catch a case.
He's like, I put on baby oil.
All right, so I'm gonna go ahead and inspect the anterior view, the lateral view on both sides, and then a posterior view, checking for any step off or deformities of the, noting for symmetry, alignment, deformities, or bony prominences. Alright, moving on. Alright, checking skin and subcutaneous tissues for edema, effusion, erythema, ecchymosis, discoloration, massive lesions. Checking surrounding musculature for any muscle atrophy or hypertrophy. And then checking the anterior posterior triangle down to the deltoids, alright? After that, I'm going to go ahead and move into my palpation. I'm going to start off at the sternal notch, both sides, right? So palpating, following the clavicle, all the way to the AC joint, which is right here. Palpating for any tenderness or bone spurs. For that, I'm going to go ahead and, I usually just palpate the bicipital groove right in here, and then move on to the scapula. Find the spine. All right, do you mind to turn around? All right.
Oh yeah.
It's pretty smooth motion there. All right. Finding the spine of the scapula, palpating the entire spine. Finding the vertebral border. All right, kind of digging in here. You can actually pronounce it more if you kind of touch your arm back. Find it, dig your fingers in there, and then relax. And then find the lateral border or the axillary border, palpate that all the way up. All right, turn around. All right, next we're gonna go ahead and palpate the subacromial bursa, which is right beneath your acromion, in the name. All right, if you can't palpate it, slightly extend the arm. You shouldn't palpate it unless it's inflamed. And checking for any tenderness of the subacromial bursa. And then we've already palpated the biceps tendon on the bicipital groove. All right, next we're gonna go ahead and, so we'll be doing that on both sides. Next we're gonna be checking for range of motion. All right, so do the same motions I'm doing. So we're gonna go ahead and flex, extend, hyperextend. All right, on flexion, we should be expecting 180 degrees. On hyperextension, it's gonna be 50 degrees. So that's past your neutral position. On abduction, so let's go ahead and go all the way out. Expecting 180 degrees. On adduction, let's go across, expecting 50 degrees. And we can check external and internal rotation at the same time. We can do the same motion as I'm doing. Like that. All right, so right here we are internally rotating the left arm, externally rotating the right arm, and then switch. Now we're doing both, all right? And we're just checking range of motion at this point. All right, next we're gonna be checking muscle strength. On the, what's it called, GMMT, or just muscle strength scale. It's 0 to 5, 0 is being no movement, 1, be muscle movement without associated joint movement. 2, unable to move muscle against force of gravity. 3, able to move against gravity but not against applied resistance. 4 is able to move against gravity and against light applied resistance. And then 5 is expected strength. All right, we'll be checking all ranges of motion of the shoulder. So go ahead and push against me, pull. All right, push against me, pull in. All right, I want you to do this motion and then this motion, all right? Go ahead and pull, all right, in. All right, 5 out of 5, both sides. Pretty quick. And then moving on to sensory. Sensations light touch on the anterior, posterior, lateral areas of the shoulder. So close your eyes, let me know if you feel the same on both sides.
Same.
All right, moving on to special tests. All right, I'm gonna do Neer's impingement sign. This is a passive test. Go ahead and put your arm out with your thumb down. I'm gonna slightly adduct. And just let me pull this out, let me know if you have any pain or clicking.
Yes.
You have an impingement. All right, this is testing for impingement of the rotator cuff. Next, we're going to be checking for Hawkins impingement sign or Hawkins-Kennedy. This is also testing for rotator cuff impingement. So we can start off right here. So shoulder flexed or shoulder abducted to 90 degrees. Elbow flexed to 90 degrees. We're going to go ahead and apply some internal rotation. Any pain or clicking with that? No pain or clicking?
No.
All right, if positive would be pain and clicking. All right, next we're going to be doing cross-body horizontal adduction test. This is checking for subacromial impingement or AC pathology, as well as impingement. So just go ahead and cross your arm over. Any pain in the clavicle?
No.
All right. All right, next we're going to be checking empty can test. Empty can test is a test that is used to determine whether they have a rotator cuff, specifically the supraspinatus. So go ahead and point your arms out and pretend like you're emptying a can. All right, slightly more abducted, and then resist my pressure, okay? You okay with that?
No.
Next, we're going to be doing horn blowers. Horn blowers is used to test the integrity of the teres minor and infraspinatus. So go ahead and we can do this with 2 arms at the same time. I would apply internal rotation while you resist. Or you do it one at a time. Internal rotation. Internal rotation. There's different ways of doing it. You can also do it like this on the side. On both sides. Or you can do it with one arm. So one arm. And then resist internal rotation. A positive would be pain and weakness to the on internal rotation. All right, next we're doing Gerber lift-off test. This is used to examine for subscapularis weakness or tears, which is another muscle in your rotator cuff. Go ahead and stand up for me. Around one hand, go to upright rest. All right, you're gonna apply resistance and then have them push against your hand. All right, go ahead and push. Okay, that would be a positive, right? Positive would be weakness or pain during internal rotation. Okay, go ahead and have a seat. Apprehension sign. Go ahead and lay down back for me. All right, apprehension sign is used to determine if they have any anterior instability of the shoulder, aka dislocations. So we're gonna go ahead and abduct flex the arm to 90, and then we're gonna go ahead and slowly apply, we're gonna start slowly applying external rotation, all right? A positive will be apprehension, where the patient feels like it's gonna pop out of the socket, or they start kind of turning into it, right? So slowly. All right, if they have apprehension, you need to confirm that with the Job relocation, which is gonna be the same motion. We're gonna be applying stability with your hand, while also applying external rotation. All right, I'm gonna do it on this side. Apprehension, if that's positive, confirm. All right, next we'll be checking for inferior instability by rolling up their sleeves. Have the patient relax, grasp their humerus or their upper arm, and pull down. A positive will be sulcus in at the glenohumeral joint. All right, next we'll be checking jerk test, which is used to determine posterior instability. You're gonna go ahead and flex the shoulder, flex the elbow. We're gonna apply, secure the scapula with your non-dominant hand or the one you're not testing with. You're gonna apply axial load on the humerus back towards the scapula. A positive would be any laxity. Do this side. All right, you can do this also while they're laying down. All right, O'Brien test. This is checking for labral pathology or slap lesions. All right, so we're gonna go ahead and put your arm out and then thumb down, right? I'm gonna apply some downward force while they resist it. All right, if they have pain with that, we're gonna go ahead and confirm by having them either palm up or thumb up and apply the same pressure. It should not be painful if they have a labral pathology. And it's only positive if it's painful with thumbs down. All right, speeds maneuver. I'll do speeds and Jurgensen. So speeds, go ahead and flex your like 90 degrees. All right, and they'll let me push you down. All right, that's speeds. Jurgensen, have them a little bit more extended. All right, and try to flex your shoulder. All right, a positive would be pain in the anterior shoulder for biceps tendonitis. All right, that's the shoulder. Next one, we'll go ahead and move on to inspection of the elbow. So go ahead and stand up for me and just kind of dangle your arms there and be noting the anterior, posterior, lateral, and medial aspects of the elbows. Noting for symmetry, alignment, deformities, or bony prominences, and noting the carrying angle. Just know that 5 to 8 degrees are normal. All right. Next, we're going to be checking skin and subcutaneous tissues for edema, effusion, erythema, ecchymosis, massive lesions. All right. Next, we're going to be checking for muscle atrophy or hypertrophy of the surrounding musculature of the elbow. So upper arms, forearms. All right, you can sit down here. All right, next one will be palpating the biceps brachii. So you can do the origin, right? The short head right here, long head, and then the insertion down here, okay? Next, we're gonna palpate the lateral epicondyle. Right, right in here. Medial epicondyle and the radial head. Or if you can't feel it, have them pronate. Go back, keep doing that. Until you find it. It's like the bone that keeps shifting. Alright? For that, we're going to go ahead and test range of motion. So go ahead and do the same motions as I'm doing. So we'll just flex, extend, pronate, supinate. Alright, job. Next, we'll be checking muscle strength. So go ahead and do a bicep curl. Alright, go ahead and do a tricep extension. Alright, go ahead and hold my hands. And then pronate, like that, and then supinate. Alright, jump. Strong as hell. That'd be a 5 out of 5. I'll give you a 6 if you had one, but. Alright, next we'll be checking sensation. Alright, sensation is light touch on the anterior, posterior, lateral, medial side. Have the patient close the eyes or look away as we evaluate dermatome sensation testing. So you go ahead and close your eyes. So does this feel the same on both sides?
Yes.
Does this feel the same?
Yes.
That feel the same?
Yes.
That feel the same?
Yes.
Right. Let me look at this really quick. Okay, cool. All right, I just didn't want to talk about the myotones yet, or dermatomes. All right, next we're doing special tests for our elbow. First we're doing valgus stress. This is checking for your ulnar collateral ligament or your medial collateral ligament of the elbow. So go ahead and secure the wrist. Apply valgus stress, which is like medial stress, to check for the UCL. And any laxity would be positive. Next we're checking varus stress, which is medial pressure on the elbow. Secure the wrist. Apply medial pressure or valgus pressure. So same thing on this side. Valgus, varus. We're going to do a long finger test. This is checking for lateral epicondylitis. So straighten out your fingers. Go ahead and push this finger down. All right, if they have any pain at the lateral epicondyle, it's positive for lateral epicondylitis. All right, elbow flexion test. We're going to go ahead and flex our elbows and extend our wrists. And this is checking for cubital tunnel syndrome or ulnar nerve compression. We're going to hold that for 3 to 5 minutes. If positive would be any numbness or tingling of the ulnar nerve distribution, which is the 5th digit, and ulnar aspect of the 4th digit. Relax. All right, next we're going to do a Tinel sign at the elbow, which is testing for cubital tunnel syndrome. It should be at the ulnar nerve or ulnar groove, which is right behind the olecranon. Once we find it, tap it. A positive will be shooting pain down to the ulnar nerve distribution of the hand, which is your 5th digit and ulnar aspect of your 4th digit. All right, moving on to hand and wrist. Let's go ahead and pop them like that. All right, checking for finger alignment, symmetry, swelling, deformity of joints, bony prominences, and then flip them over. We're checking the contracture of the palm or loss of the arch. All right, then checking for skin and subcutaneous tissues for edema, effusion, erythema, ecchymosis, masses, lesions, and then flip them over, and any nail deformities. All right, and then we're gonna go ahead and check, flip them over again. We'll be checking for atrophy or hypertrophy of the thenar eminence, which is your muscle here in your hand. and then also checking for musculature up in the forearm. All right, we're gonna flip them over. We're gonna go ahead and palpate the ulnar styloid, down here, radial styloid, the metacarpal phalangeal joints, which are gonna be on the metacarpals 2 to 5, right? So, sorry, 1 to 5. So, one's right here, one here, one here. You broken your fingers before?
No.
This one's like sunken in. All right, so palpate all the MCPs. Next, we're gonna go ahead and palpate the PIPs, which is your proximal interphalangeal joint, right here, on both hands. Then move on to our DIP, which is your distal interphalangeal joint, which is all the way at the end. All right, next, I want you to do this motion. Palpating the anatomical snuff box. He has a big one right here. So just palpate. You can show them right in there. All right, checking. So the reason why we palpate the anatomical snuff box is to check for any scaphoid fractures. All right. Moving on, we're gonna be doing range of motion of the wrist. So flexion, extension, radial deviation, the other way, radial deviation or abduction, ulnar deviation or adduction. All right, and then for fingers, we're going to be doing finger flexion, finger extension, or finger abduction, adduction. Moving on to the thumb. All right, so we're going to be doing thumb opposition, going all the way across to the base of the 5th digit. Flexion. Flexion. I don't want to be anxious by moving my hand. All right, flexion, extension. All right, abduction, adduction. All right, next we'll be checking strength. So go ahead and close your fist like that. Let's get a couple more like that. So first is going to be for wrist flexion and extension. So when I hold your hands, I want you to go down and then go back up, all right? So down, up, and then palms out. When I hold your hands, I want you to go like this and then like that, all right? So radial deviation, ulnar deviation. All right, it's equal, 5 out of 5. All right, next, for finger extension, go ahead and I'm gonna have you grip my fingers and I want you to squeeze. And then I'm gonna go ahead and hold you in a fist and I want you to open up, all right? So, squeeze. All right, I'm gonna just do one at hand. Squeeze. All right, so flexion, extend, extension, and then thumb abduction. So fingers like this. I want you to push up against my hand. All right. Now do it. Do it. All right. And then last, we're gonna be checking grip strength. So go ahead and squeeze my fingers. All right, we'll do it one, just so everyone can see. All right, next we'll be checking sensory of the force, light touch, median nerve, ulnar nerve, radial nerve. All right, so go ahead and close your eyes. Does this feel the same on both sides?
Yes.
Does this feel the same on both sides?
Yes.
All right, so right here I checked radial nerve distribution, right, the first web space of the hand, and flip them over. Next, I'm going to check the ulnar distribution, right, ulnar nerve distribution of the hand. So it's going to be these two fingers for the half of this one. So checking, does that feel the same?
Yes.
And then we're going to move on to the median nerve. Does that feel the same?
Yes.
Okay. All right, next we're going to be checking the flexor digitorum superficialis. which is the tendon that moves your middle phalanx, right? We should be doing this on every finger. I'm gonna do it on one hand. So secure the PIP, and have them flex the finger, right? Flex, 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 flex. All right. We do that on both sides, right? Next, we'll be checking the flexor determined fundus, which flexes the distal phalanx. So secure the DIP, flex, 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 flex. All right, next we'll be checking Tenel sign at the wrist, which is checking for carpal tunnel syndrome or median nerve compression syndrome. So just have them kind of rest their hand on your hand and then just tap at the middle part of the wrist. A positive would be shooting pain or paresthesias down to the median nerve distribution. All right, so we're talking about carpal tunnel syndrome. We're going to check for failing maneuver. Failing maneuver, you have them flex their shoulders, flex their elbows, and extend their wrist. Flex their wrist. All right, put them up against each other and have them hold it for 30 to 60 seconds. A positive would be paresthesias down to the median nerve distribution, which is the radial aspect of your fourth digit, and then all of your third, second, and half of your first. All right. Finkelstein maneuver. This is checking for decurvent tendinosynovitis. So go ahead and tuck your thumb in like that. It's going to be a passive range of motion. Have them rest their forearm on your forearm, and slowly and in a controlled manner, ulnar radiate, right, or ulnar deviate. A positive would be any pain at the radiostyloid. All right. And then we're going to go ahead and move on to Froment sign. Froment sign is a test that is used for any ulnar nerve palsy. So the ulnar nerve controls the thumb opposition part of your thenar muscle. So we're going to have them hold on to a piece of paper with their thumb flat, fully extended. And then you're going to have them hold on to it tight while you're trying to pull away. All right, a positive would be flexing of the thumb, and a negative would be the thumb just stays flat. All right, that is the PCL for upper.